Well, hello everyone, and welcome to today's March Wins webinar for supportive housing. This month, we're going to be talking about suicidality in supportive housing programs and kind of how to navigate that and support the individuals that you work with in your programs. Today, it'll be myself, Dawn Reinhardt, and my colleague, Emily Bands, both from Rutgers University. So welcome. Just a little housekeeping. Again, we want to welcome you. And today's webinar is hosted by DBHR through the Washington State Healthcare Authority. This is an interactive training, and as always, we encourage you to ask lots and lots of questions and participate throughout this session. Not just ask questions, but offer your, personal professional experience as well. The slides, as well as a link to this recording, will be sent by email after the presentation. And just a disclaimer, a note about the use of artificial intelligence or AI. Please note that the use of automated note-taking bots or similar tools during Washington FCS events or meetings requires prior approval. Excuse me. Unauthorized use of such tools is prohibited to ensure the privacy and confidentiality of all attendees. Also, any recording that is created through AI is not recognized as an official recording of this session. We reserve the right to exit trainees, hopefully we don't have to do that, from the training if they are using AI to take notes without prior approval or using AI to record the session. And just to let folks know that in terms of your audio and video are muted at this time. You can use computer audio or call in to listen. To ask or respond to questions, please use the chat and make sure that you're selecting the blue next to the two there in the chat, the bottom of the chat window. Please make sure you're selecting everyone, unless you do want to post a chat or question or a comment just directly to Emily and myself. That way everyone can see it if you select everyone. You can download the entire chat that is generated today throughout the webinar by clicking on I think it's the three little buttons all the way to the right of to everyone, or right to the right of the little emoji smiley face. And it will give you the option at the top to save the chat if you would like to do that. And sometimes that's helpful because people may share resources or other interesting points or things like that in the chat. And for accessibility issues, subtitles are available. To see subtitles, you want to click on the three little buttons in a circle at the bottom, I think, of your screen, or it says more, show subtitles, and you can contact either myself or Emily, shoot a chat to hosts and panelists, or in the general chat if you need any additional help with captioning. And just to let you know, the webinar is being recorded and the presentation and recording will be shared with all of you. So today we have a few learning objectives that we really hope to cover thoroughly and convey to you. And the first is that we want to recognize populations with the highest rates of suicide. So we're going to be taking a look at some of the most recent statistics around individuals, who die by suicide and certain demographics. We would like to identify the risk factors of suicide so that we all kind of raise our awareness and are more aware of what those risk factors look like. And just finally discuss services that supportive housing staff can provide to individuals who are at risk of dying by suicide. And so I do want to mention, it can be, we have a lot of folks in different roles that are in, that participate every month. This could be a sensitive topic. And we just do want to say that, if at any time you are in distress or anything, please feel free. We know, folks may need to take a break, step away. That is absolutely fine. And we want everybody to take care of themselves first. So I just wanted to make that little point. Next slide, please. So let's start out by discussing some of the facts and figures statistics around suicide. So, I think sometimes folks have a misconception of, who dies most by suicide, age groups, et cetera. And so it's really good that we, take a look at this and see where the statistics, I'm sorry, actually lie. And this is within the United States. Figures will be different globally, but we're concentrating on the United States here. So in terms of age, almost 47%, so a little less than half of all individuals who died by suicide in the United States were within that middle age, I would say, range of 35 to 64 years old. There may be many factors around this. Folks may want to post in the chat, why they think this may be, or if you have worked with individuals who may have died by suicide in this age range, were there certain things that the individuals were dealing with, risk factors, maybe health issues, financial issues could crop up, during this time, relationships ending and so forth. So that is, pretty much the majority proportion of individuals are within that age group who die by suicide. The highest rates are actually for Native American or Alaska Native men, which is about 41 individuals per 100,000. So 41.3 deaths by suicide per 100,000. That's a population statistic. Second highest rate of death by suicide is for non-Hispanic white men, almost 36% or 36 individuals per 100,000. And I'm sorry I do that. Sometimes I fix a percent, but it's not percent, it's individuals, deaths per 100,000. Excuse me. Highest for Native American or Alaska Native women. So in terms of proportion or demographics for females, it is the highest for Native American and Alaska Native women at almost 13 individuals per 100,000. And second highest for women is non-Hispanic white women, almost 11 per 100,000 individuals. And adults age 75 and older have the actual highest rates of suicide, which is 20.3 per 100,000. Men in this age group had the highest rates overall at 42 per 100,000, with non-Hispanic white men having the highest rate, so 50.1 individuals per 100,000. So again, looking at that, we're talking about men within that 75 or older age group actually have, they're the gender with the highest rate. So how about this age group? We're talking about seniors here. Perhaps, so I'm looking at Sage just made a comment, and I was just going to ask, what do you think maybe some of the factors are? Not just, let's look like gender-wise, and then also age-wise, some of the factors that might contribute to a higher risk level for suicide. And Sage just commented, and this is accurate, that some individuals state that men tend to have higher death by suicide rate due to them choosing more lethal means. So, and do we know if this is accurate? I don't think it's the number one cause, but I think it's a huge factor in whether or not an individual there's a lot of terminology and I like to be ginger with it, but I worked in crisis and screening for a while, and we would say if individuals complete suicide, very often it was because of the lethality of their means, right? It might be gunshot, it might be using a motor vehicle as a means to complete suicide or to die by suicide, just more lethal to the human body means. This does not mean that, medications, cutting, things like that could be any less dangerous to an individual. So we should take all threats seriously. And whenever anyone states that they have a plan and a method, we really need to take that seriously. So let's not discount, pills or knives or anything like that, just because an individual doesn't own a gun, or some other, very lethal means. But so that is one factor. So thank you, Sage. I appreciate you offering that, because that is something that, when I worked in crisis, one of the things that I wanted to know was, does this individual have access to a firearm? Because that made the chances, that much more, that the individual could die, or another individual could be injured in, maybe the attempt. Um, Right. So Rosalita also mentions that something that also immediately comes to mind as a factor in these statistics could be isolation from community. Absolutely. Right. And if you're talking about populations that may be smaller, more isolated, right? I know here on the East Coast, we don't have a huge Native American or Alaskan Native population, right? So, and I don't know what that looks like in Washington. But if people are living in more rural areas, maybe with less access to mental health or other treatment options, that could also be a risk factor, right? Or also individuals that they feel as if maybe the outreach to the community isn't as good, right? So yeah, so thank you for that. Those are really great points. The other thing that we need to think about when we consider older adults, and when we talk about individuals who have serious and persistent mental illness, who are, living with mental illness, that could be potentially disabling. The other thing that we know is that folks tend to age more rapidly. So individuals around my age of 49 who may have a serious and persistent mental illness may have a lot more comorbid medical conditions than an individual without a serious and persistent mental illness at that same age, right? So folks tend to die on average earlier from physical ailments, within that group of individuals who have serious and persistent mental illnesses. So it's almost aging starts earlier, right? So one of the things that we also need to consider is folks in that age group may also have access to more lethal means of medications, in addition to having many more medical conditions, other physical conditions other than their mental health condition. And we know that medical conditions can be a great stressor for individuals, physically, emotionally, monetarily. Um, and also because they may have, serious medical conditions, their access to those more lethal means like blood pressure medications, insulin, other cardiac medications that could really, perhaps pain medications, could really, uh, you know, um, I would say allow, but be a means to an individual to be able to end their life, even without a firearm or another type of weapon. So older adults is an age group that we really need to, we need to pay special consideration to every group, but to understand that those risk factors do increase their likelihood of death by suicide. Also, we do know that men, in my dissertation research, one of the things that I was looking at was the promotion of sexual health education for individuals in supportive housing programs. And one of the things that we see in men in particular is that they may stop taking certain medications, especially antidepressants, SSRIs, because they can have really deleterious effects on libido and sexual health, for individuals. And so folks may be, not taking their meds and maybe becoming increasingly depressed because those medications affect their relationship with their partner or how they feel about themselves physically. And so there are a lot of these kinds of um, decisions that people may make based on how they feel, that could affect them in the long term, mental health wise. And so we need to have these really open conversations and work, with shared decision making when people are electing to take medications and so forth, so that we can maximize the benefits versus the risks. So I see a few comments in the chat, and I want to address them. So Chris says that they have a number of clients in that range and notice that it tends to be due to persistent pain and medical issues. Imagine being in persistent chronic pain, right? I know someone who was married to someone with persistent chronic pain at one point, and saw the effects emotionally, mental health wise, that the person had to, that the person had due to being in pain constantly, right? Life options and connections begin to diminish, right? Like folks may not be able to work anymore. Maybe their social network is starting to narrow because people are passing away or moving away or may go into nursing care, those, or just become more isolated, right? And also, Chris says that that age has had time to encounter many barriers that they may not have overcome yet, but are still faced with it. That's deeply impactful. Like when I think about that, when you think about perhaps barriers, whether they be, real, I don't say real, but perceived or in reality, right? How maybe we feel about ourselves or what kind of options we have or opportunities we did have or didn't have in our lifetime, that could be very overwhelming, especially without the appropriate supports. Sage says that a lot of elders that they've worked with also express a general feeling of being tired, especially as loved ones, such as partners, close friends, and siblings, pass away. I will say that when my 91-year-old grandmother was in the last couple years of her life, she would very frequently say, I'm just done. She didn't come off as depressed or wishing for suicide. There was never an attempt. She was treated for depression at one point. But it was, I'm just tired. I'm just done. My husband is up there. My friends are there. Some of my, other relatives are there, and I just want to be there. I'm alone in Florida, right? So there is that general sense of that collapsing social network and just being tired, right? To also note that tiredness and fatigue is a symptom of depression and anxiety as well, too, right? So we don't want to overlook anything as just a normal course of aging as well. All right. And Shannon states that collapse of key life components. Yeah. Financial collapse, medical collapse, relational collapse, prescription collapse, mental health collapse, emotional collapse, existential collapse, political collapse, right? So seeing things that you never thought you'd see happen in this world. I know that's happened to me recently, over the last 8 years. And can have significant effects on an individual's emotional, mental health, and relationships, etc. Ideological collapses, right? I thought I believed in this thing and it was nothing, right? Or I was deceived. Just a lot of things falling apart, devastating future tripping, and many moving parts. Thank you, Shannon. I think you spoke really well to that towards that point. And Karina, um, wanted to check in about the understanding of the statistics. So yes, adults 75 or older have actually the highest rate per 100,000 individuals in the population. So it's a population statistic. So it sounds a little bit more confusing, or it sounds a little confusing when compared to that top box. They're both population statistics. So it's just, if you look at the number of individuals, how do I explain this? If you look at the number of individuals, within the populations who are 75 or older, that group actually at a rate point, if you look at, you see here, 42.2 and also 50.1, right? But if you look at that rate point, the rate point is higher than the others.
Can I?
Can you, Emily, do you want to clarify that anymore? Because I am terrible at population
Yeah.
statistics.
Well, I think also something to consider is what you mean by at risk, right? Because I think risk is something that can be very individual to a person, right? You can have a consumer that you're working with that might not be in this group, but could have a very high risk. And we're going to talk about risk factors in a little bit, because there's a lot to kind of consider when it comes to risk on an individual level. If we are looking more broadly at the population, then technically, per these statistics in 2023, yes, these individuals were most at risk, but these are the statistics from 2023. They have yet to update statistics to be more recent. These numbers could essentially change.
And also these are deaths by suicide. So
Right.
these also aren't capturing attempts.
Yes.
And so that's something you also want to keep in mind is perhaps we're not sure. I don't know. I don't want to speak to this. It perhaps there could be more attempts in another group, right? I don't know that, so I don't want to say that that's factual, but just to make that distinction that these are deaths by suicide, not attempts. So it doesn't capture that additional data. You're welcome, Karina. I hope we explained it well. I know Emily did. I did not. Next slide. So let's look at race and ethnicity and kind of dive into that a little bit more. So the ninth leading cause of death for Native American, Alaskan Native individuals is suicide. So, it is between 15, let's see, yeah. So the suicide rate of non-Hispanic Native American or Alaskan Native individuals between the ages of 15 to 32 is 82 individuals per 100,000 people. That's a very high population rate for death by suicide. That's very high, alarmingly high. The 11th leading cause of death, it is the 11th leading cause of death for Hispanic and non-Hispanic people of all races. Um, and rates increased among Hispanic, Native American, Alaska Native individuals about 26%, and non-Hispanic Black individuals 19.2%. Rates declined about 4%, excuse me, for non-Hispanic white individuals between that same time period. So we saw an increase in two groups, Hispanic Native American, non-Hispanic Native Americans, Alaskan Natives, and also non-Hispanic Black individuals. Their rates increased while non-Hispanic white individuals dropped in that same 3-year period. One of the things, could we go back one slide? Looking at those statistics. Oh, the next one in, sorry. I was just curious if anybody else noticed, that during this time that these statistics were looked at, it was during COVID time as well. And so when we consider things like additional stress, additional loss of social network, whether it be people are literally dying, or that the social network is not, we can't access our social network as well, right? We couldn't at that time. And so, we also want to think about that in terms of those collapsing social networks and those during times of pervasive crises, meaning the entire community, perhaps the entire nation, perhaps the entire world is being affected by a crisis. During those times of pervasive crises or disasters, those rates could, increase, risk could increase due to isolation and other risk factors. Next slide, please. Okay, so let's take a look at some risk factors. So we have things like personal characteristics. Um, whether they be, an individual's, uh, you know, uh, symptoms that they may be experiencing. And Emily, you can help me with this one as a therapist. Symptoms that they may be experiencing, stressors in the individual's life, perhaps support net. You chime in. Okay. So the personal characteristics like their physical conditions, any kind of when we're looking at their age, like what are the things that happen during those developmental time periods that people are in, right? So the age, we know that older adults and we said adolescents also are at greater risk. Males, we kind of talked about what some of the reasons might be that they're at greater risk for death by suicide. Some of those including access to more lethal means or willingness to use more lethal means of suicide. Those of non-Hispanic, white um, uh, racial group are at greater risk. Having a chronic or serious physical health condition. Again, we talked about individuals who are older adults. And when we talk about folks that we work with, we have to kind of tweak our understanding of what an older adult is. Because again, like I said, I'm not 50 yet. And there are individuals that I have worked with who are about my same age and had an overwhelming number of, comorbid physical health conditions that they struggled with. And so we want to, be aware that that age of kind of like the older adult kind of physical health issues, the onset will be maybe earlier in this group that we're working with. Individuals who recently experience a loss, whether it's a death, loss of relationship, loss of job, loss of pet, especially, when you're talking about individuals who may otherwise be isolated, we can't minimize these types of losses, even if it's not a death of a close individual. And lack of social support. So again, maybe a narrow or non-existent social network. Obviously, individuals who are living with a mental health or substance use disorder, or both, are at risk for death by suicide. Any history of a mood disorder, whether it be, major depressive disorder, which once an individual has a major depressive episode, they're more likely to experience one in the future. Whether it's bipolar disorder with mood swings between mania and depressive episodes, which could be very, very risky for individuals living with bipolar disorder, going from a manic state where one feels more energized and perhaps, an elevated mood to something that is, depressed, a depressed mood. That crash can be, very risky in terms of, elevating that risk factor for suicide. Alcohol use, one statistic that I saw that was that a majority of death by firearm, suicide death by firearm was preceded by alcohol consumption within the 4 hours or so before the time of death. And so we know that alcohol lowers inhibitions, and also it is a depressant drug, and I will call it what it is. It is a depressant substance. And so individuals who may be at risk for suicide or have other mood disorders have to be very cautious with their use of alcohol, because, again, it's a depressant and it's a disinhibitor. So you may do things that you wouldn't usually have done if you weren't under the influence of alcohol. And also you may be in a more depressed state and your thinking may be clouded. And psychosis. So individuals experiencing psychosis, folks who may be have distortions of their perception of reality, may feel persecuted, may be experiencing delusional thinking, may be experiencing command hallucinations, telling them to harm themselves or telling them very awful things about themselves, could be at greater risk also for suicide. And then we have other behaviors and feelings. So, folks who are exhibiting more impulsive behaviors or more aggressive behaviors may be more likely. Feeling hopeless is one of the reasons why we ask this question when we do a depression screening. How do you feel about the future? And even if not asking that question specifically, but how does the person talk? Are they future oriented? Do they talk about, we call it being goal oriented, right? Do they talk about things that they want to take care of? Do they talk about, they got to do the dishes tonight? Or, I mean, that's not something exciting, but are they talking about going to work tomorrow? Are they talking about seeing their friends next week? Are they talking about, these sorts of things? Or has the discussion of future kind of ended or subsided? Helplessness around current situations. Sometimes people feel as if, or they can't, because of decision making and maybe, some cognitive issues, or just feeling emotionally overwhelmed, can't see a way out of their current situation. And when we get to history, past attempts, past personal history of attempts are a one of your greatest predictors of future attempts. We not only say that about suicide, we also say that about when we talk about things like violence. Previous violent acts are the best predictors of future violent acts. Previous suicide attempts are the best predictors of future ones, right? And if they have had previous attempts, we want to know what it looked like as much as you can get out of the individual. What did it look like when you were feeling that way, right? So we know some of the signs to look for. Attempts by family or friends. So people with a family or friend circle history of suicide, are at a greater risk. We also know, like with younger individuals, I work on the disaster response team for my county here in New Jersey. And when we respond to events in the schools where there's a death by suicide, one of the things that we want to know almost immediately is who are their friends. And maybe not even who their friends are, like who are the kids that you think may be at risk at this school, because things like contagion can happen, right? One person does it and another person may be thinking about it and they may attempt. And we actually had that happen locally here in the town I live in a few years ago, and it was pretty devastating. So we want to know, have there ever been any attempts? And because that looks like an option to an individual, right? When we hope it should not be. And plans and means. So this may be like when you're doing a crisis screening, do you have access and do you have a plan? And if so, what is it? Like if a person says, well, the next time I'm on an airplane, and this isn't to make light of it, but the next time I'm on an airplane, I'm going to jump out of it without a parachute. Well, that's really unlikely that's going to happen, right? And that doesn't mean that the person's not serious, anything like that. But you really want to, do they have quick or immediate access to these means, right? And how solid is that plan? Okay. Emily, do you have anything you want to add here?
Yeah, so going back to the personal characteristics for a second, things like gender and age, I think in terms of thinking about the statistics that we went over, those things don't really change. Men, historically speaking, have just been more likely to die by suicide. Older adults, again, have been so we can talk about sad persons in a little bit, Carrie, actually, because I'm going to actually give you a different acronym that's a more updated one. But things like gender and age historically have been pretty consistent. Older adults and adolescents tend to um, be more likely to die by suicide, and men are more likely to die by suicide. In terms of with race, I want to say at the time, this source is from 2015, and I think that's why it's highlighting Caucasian. But we know now, as of 2023, that it's different, right? We know that I'm just going to go back to the slide for a second because we just said it, right? So for non-Hispanic white individuals between 2018 and 2021, the rates declined, but increased for non-Hispanic Native American Alaska and Alaska Native individuals and non-Hispanic Black individuals. So those individuals are also now at a higher risk, right? So a lot that aspect of it really, I think, just speaks to the different trends related to dying by suicide. Again, having a chronic or serious physical health condition, like depending on um, what that looks like for the individual, if the person is unable to get treatment, right? I think that links very much to, which is my next point, that there is some overlap with some of these, right? So when we're thinking of someone who has a chronic health or a serious physical health issue that cannot be treated, that's going to lead to hopelessness regarding their future, right? That's going to lead to a feeling of helplessness about their current situation because it's not something that can change. So just kind of thinking about how some of these um, factors are things that can't change, and some of them can, depending on the situation. So just kind of being mindful of that. And Brady, we're actually going to get to how to assess a little later. So we will definitely get there. But that's all I wanted to add, Dawn.
No, that's fine. And I just popped in the chat that I think stats are important. And folks may have heard me lamenting about doing statistical analysis for my dissertation.
Right.
So stats are inferential statistics and things like that, or descriptive statistics, are important, but you don't need to memorize this. It's
Mm.
more about like outside of, the male gender and then the age. And I think the age really, both of them also are associated with, well, what does that mean? Is it access to all of these other things, or that might be, increase the risk. So I would also say that like where stats are important, what is even probably more important is what you know of the person that you're working with and
Right.
perhaps deviations from that person's norm, right? Sometimes people speak uh, uh, in a very depressive way, right? So some people are, may speak like they may feel hopeless all the time, and that's not to say like don't discount that individual as having a risk factor, right? Because you definitely want to check in with that individual, but to also say when you see like um, when you know that an event has happened or that you see a significant change in an individual's behavior, also pay attention to that, right? Regardless of what their age is, what their gender is, what their race is. We don't want to over rely on statistics and forget about the human being in front of us and our relationship with them.
Mhm. Because at the end of the day, to your point, Dawn, somebody can have all of these risk factors and never try to die by suicide.
Absolutely.
Like,
Or
so,
we don't know, may have attempted 12 times,
right.
right? And
And
never entered into a hospital or anything like
right.
that. So,
These I like to think of the statistical information we went over and these risk factors as just like red flags. So when you're looking at, like Dawn said, the individual and the person you're actually looking for, how many red flags do they have? Do they have these red flags? If they do have these red flags, then you want to just increase your awareness on that and be mindful of that in your work with the person because they could mean something or they might not mean anything.
right, right. And I think especially, when we look at the rates for non-Hispanic Native Americans and Alaskan Natives, I think it's good to have information such as that because I think one of the things that it underscores is an underserved population, right? In terms of behavioral health services, substance abuse service, substance um, uh, um, abuse treatment, and so forth. And so it is important to kind of know that, wow, what does that tell us? What does that mean to be aware that this is an underserved um, group of individuals. So thank you. Okay. So you may also work with individuals who may engage in self-harm, may state that they're going to harm themselves. And so let's talk a little bit about that. Um, one of the units at the hospital that I consult with has a what they call a DBT unit, behavioral treatment unit, for individuals who are at great risk for self-harm. This unit is all female. And as you know, often DBT is utilized for individuals who are experiencing borderline personality disorder, who have been diagnosed with that, but it can also be used in the treatment of depression and anxiety and so it's being used more and more for other or to address other mental health conditions. But when we talk about self-harm, this is something that again, depending upon the type of mental health condition that an individual is experiencing that you're working with, they may be at greater risk of this. Individuals with borderline personality disorder are at greater risk, and so I just wanted to note that. So self-harm is defined as non-suicidal self-injury. So, has anybody ever worked with an individual who engaged in self-harm, and maybe what did that look like? I've worked with individuals where it was, scratching, either with their nails or other tools. In the hospital, we have to make sure there's no staples in things like magazines because people may scratch with them. It could be hair pulling, cutting, and other modes of harm. Biting oneself, pinching, we've seen. And it is a coping skill and so we have to consider this when we're trying to remove that activity of self-harm that the individual is engaging in. It's a coping skill that's used by the individual to achieve a sense of control. So folks will tend to engage in self-harm in an attempt to regulate their emotions, whether they're feeling very, very overwhelmed or perhaps maybe feeling numb, right? It may be used to distract from emotional pain. So the individual may engage in a physical release of pain to distract from the emotional. Counteracting, as I just said, counteracting numbness or the feeling of dissociation. So an individual may engage in self-harm to feel. to feel present, and to also bring themselves back from a state of dissociation. It may also be used as self-punishment. So if an individual is feeling, guilty, worthless, bad, really bad about themselves, they may engage in self-harm. Interpersonal influence. So, this could happen, and Emily, I'm going to ask you to elaborate on this one, but this may also happen, in terms of relations with other individuals who may engage in self-harming type behaviors, as an outlet for, seen as an outlet for this type of emotional dysregulation. And again, when we talk about emotional dysregulation, that is, the individual not being able to kind of transition between or to control feelings of anger, sadness, stress, anxiety, right, on their own. And interpersonal communication. So an individual, may engage in such behaviors, within or after maybe a stressful kind of communication event with another individual. And Em, would you like to elaborate on any of that? Yeah.
Yeah, so when we're also thinking about self-harm, and I know that adults do use self-harm, but typically adolescents are individuals most likely to use self-harm. Adolescents, teenagers will use self-harm, and then as they get older, sometimes, or I will say for a majority of folks, it does stop. Obviously, that's not everybody, because there are adults who do participate in self-harm behaviors or non-suicidal self-injury. But the interpersonal influence and interpersonal communication, I think the specific examples from the resources had to do with teenagers and adolescents. So if a teenager notices that a friend is participating in non-suicidal self-injury, they then may begin to participate in non-suicidal self-injury. Same thing with interpersonal communication, right? We had a case a couple of years ago where it involved, I think they were two people in their late teens, early 20s, where the girlfriend essentially told the boyfriend to harm himself, and he did, and he ended up dying. So that can happen as well. And there's a lot of things in the chat, Dawn. I don't know if you want to get to that.
Yeah, absolutely. So, let me scroll back a little bit. Sage stated that they've worked with a number of folks who self-harmed and they're in recovery from self-harm myself. So I applaud your work and your recovery. Really do. And they said that they've seen cutting, burning, hitting head or other body parts, forced vomiting, and even exercise used as a form of self-harm. So there is something that is referred to as, uh, I think it's exercise anorexia, where individuals will work themselves out to the point where it can cause, disturbances to your electrolytes, and so forth. And you could go into cardiac arrest,
Mhm.
by doing so. Um, and yeah, so Chris asks, in this definition of self-harm, are we including overindulgence in substances like alcohol as well? I think that's what do you say, Emily? Let me ask the expert.
I think it has to do with the
The
intent.
intent, right?
Yeah, I mean, if I think, and here's the thing with that also is the person consciously aware of the consequences, and are they aware of the fact that participating in this behavior is going to harm them? And I think if the answer to that question is yes, then yes, that could potentially be categorized in this idea of non-suicidal self-injury. But I think the intent is really what matters. There are plenty of people who like overindulge in substances, and their intent is not to harm themselves, even though that's the
It
consequence,
could happen. Yeah.
right? So it's important to kind of we know that, right? We as professionals with this level of education know that if you participate in this behavior, there could potentially be long-term consequences, but that person might not know or might not be aware of those consequences. If they are aware and they, would still prefer to participate in that behavior, then it could potentially be non-suicidal self-injury if they want to harm themselves.
Yeah. Right. So it's about the intent.
Yeah.
Yeah.
And I think that leads into the last point, Dawn.
Right. That self-harm doesn't always equal suicide, right? I worked with an individual who repeatedly, maybe a couple times a month, attempted to harm herself. She would throw herself down. She would fall down steps. The culminating event was that she sat in the middle of a highway, um, right out in front of the office building that I worked at that time. And we had been trying to get her into a facility for treatment, and folks walls were being pulled up until that culminating event, which could have been very tragic, for not just herself, but other people on the roadway, right? And she literally sat in the middle of a highway. And so, we do have to although self-harm doesn't necessarily equal suicide, and perhaps the person's intent is not to die, but it could very easily happen, right? Especially if the methods start to change and they maybe become a little bit more lethal. Okay, so looking back at the comments, um, Jerry states that they worked with a woman who used a rock to hit her face to make herself unattractive to others. We do see sometimes, I don't know if the person was a victim of any kind of sexual assault or abuse, or perhaps a psychosis, not sure, but we have seen individuals who have been victims of sexual abuse or assault, use items to make themselves, in their mind, less appealing or less likely to become victims again of sexual abuse or assault by harming, by mutilating their features, whether they be facial or otherwise, to make themselves less appealing. And so, that can also lead to catastrophic medical events as well. Punching themselves in the face, stabbing own leg, yes. And Alvin states that they worked with a gentleman who would injure himself all types of ways, hitting arms and legs on things, right? And so it could, there could be no tools utilized, there could be varying, but again, this is about the intention, and also the understanding that at any point this could escalate and become a lethal event.
Right. Mhm.
Next slide, please. Okay,
Mhm.
I'm going to go ahead and hand this over to Emily now.
I'm up, Dawn.
Okay.
So I do just want to acknowledge what Sage said. So I knew someone who cut themselves but didn't know how sharp the knife was and ended up cutting through the tendons in their wrists. There can be very serious lasting damage with self-harm, even if the person isn't trying to cause that long-term harm. Absolutely. And again, just kind of thinking for a second back to what non-suicidal self-injury is, very specifically, the intent behind that is that coping skill to achieve a sense of control. But there can be consequences to using that coping skill, depending on, especially if it's something like self-punishment. So thank you for sharing that, Sage. And it's hard, right? Because again, it's kind of like the chicken and the egg, right? So not everybody who participates in non-suicidal self-injury um, uh, goes on to die by suicide, but it is a risk factor. And I think in terms of answering this question of how can you support consumers in your supportive housing, I think the first step to that is understanding these risk factors and understanding the personal characteristics, the age, the gender, the different experiences, the behaviors, understanding how those do contribute to a person's risk. And now that you understand that and have that information, now you can begin to work with the person. And the first thing you can really do is strengthen those protective factors. So essentially, protective factors are the things that people have or can gain that can essentially support them in sort of balancing that scale of am I dying by suicide versus not dying by suicide, right? So protective factors are reasons for living, right? So helping the person and supporting the person and seeing what their reasons for living are, strengthening them. What are their valued life roles? What are the different activities that they participate in day to day? What hopes, dreams, and aspirations do they have? How can they work to attain the different recovery and rehabilitation goals that they have? Having access to treatment and supportive providers is also a protective factor, right? So the fact that you are going out there and you are meeting with individuals and you are providing that support to them, that in and of itself is a protective factor. The therapeutic relationship between and rapport between a service recipient and a provider can be a protective factor, but at the same time, if the person that you're working with does die by suicide, it's not your fault and it's not our fault. Having a good therapeutic rapport can be helpful, but at the end of the day, the person that you're working with is going to make the choice that they're going to make. And it's also important to understand that. So I say this and I acknowledge this, but also with that caveat. Having strong personal relationships, right? The different individual personal relationships that the person has, maybe with friends, families, acquaintances, um, going and kind of overlapping with this idea of religious or spiritual beliefs. Are they involved in a religion? Are they involved in some type of community, whether that be a religious community, whether that be a hobby or a community activity? Those personal relationships are going to be a protective factor in the same way as having a strong religious belief, right? I've worked with clients personally who have had passive and active ideation, but have whatchamacallit, but have had stated very clearly, I would never die by suicide because it's against my religion. So having those religious or spiritual beliefs can also be protective factors. Having a strong self-efficacy, self-esteem, having good coping skills, those can also be really good protective factors for both for folks, right? So when people believe in themselves, when they believe that they can do things, when they believe that they're capable, when they have a good repertoire of coping skills, those things can also be protective factors. And then resiliency. And I also say resiliency with a caveat, right? Because I think people talk about resiliency and, we just have to be resilient, and it is easier said than done, right? I think we would all prefer to not be in a situation where we have to be resilient. So I want to acknowledge that. But having a sense of resiliency is something that can be a protective factor for somebody when it comes to a person managing or navigating suicidal ideation. The other thing you can do is pay attention to these warning signs. Okay. So again, we're looking at data in a way. We're looking at red flags, things to kind of be mindful of. So if you are working with somebody and they are talking or writing about suicide, that's something that could potentially be a warning sign. Someone wishing or wanting to be dead, someone lacking personal hygiene or care of their appearance, right? Maybe it's somebody who typically does really care about their appearance and does typically have really good hygiene. And now that's something that's changing. A declining of mood or symptoms, experiencing a loss or crisis, or on the reverse of that, a suddenly improved mood, right? Let's say you're meeting with somebody in the past couple weeks, they haven't been feeling well. They've maybe expressed some ideation, whether that be like passive or active, but now you go and meet with them and their mood has suddenly improved, but there's no reason, or they don't want to share the reason. That could potentially be a red flag, because that could be because the person has it in their mind that they are going to die by suicide. So now they feel better. Someone who is developing a plan, someone who is withdrawing from relationships, someone who is taking steps to prepare to act on a plan, and then saying goodbye. This idea of saying goodbye, sometimes I've seen people talking about giving things away, giving items away, giving belongings away while they're saying goodbye. Is anybody familiar with these warning signs? Is this new information, old information? Does anybody have any experience with any of these warning signs? Thank you, Chris. A similar one that you've been trained to look for is an upsurge of generosity or donating out of nowhere. I think that's also a great thing to be mindful of in terms of somebody maybe who is very particular about their belongings and about their items and the things that they own, now wanting to donate things and give things away. That's definitely something to be mindful and aware of. Um, Teray, I hope I said that correctly. Wishing or wanting to be dead is the most common you've experienced with clients. And yeah, that passive ideation, right? That sense that the person has and feels that they don't want to be here anymore. That's a really big warning sign. Did you want to add anything, Dawn? Or any other warning signs? Sage, you said years ago a friend was saying goodbye, but none of us noticed. He was framing things as, I just want you to know how much I appreciate you and value your friendship. And so those of us he connected with before his suicide went unnoticed. Yeah. And that's devastating. And I think you, Sage, for sharing that. I can't imagine how hard it was for you to you lose your friend that way. Um, but it's unfortunate because I think unless you are paying attention, right, it can be really hard to recognize these things. Denise, you said yes, these seem to be typical. The hardest to pinpoint is a sudden uptick in mood. Right.
And also think about that, right? When we talk about an uptick in mood, if you're working with an individual who has experienced depressive symptoms, right? And perhaps they're taking a medication and something that we might think is, wow, maybe the medication is finally working, right? Or for youth, for younger adults who are started on antidepressant medications, especially in the SSRI class, we have to look for um, uh, signs or warning signs of suicide because one of the first things that an antidepressant can do is kind of lift your energy level and make it so that you don't feel as fatigued and you are able to do what you plan to do. But if some of those depressive symptoms are still there, if what you've been thinking about is death by suicide, you may now have the energy and the cognitive capacity to do that. So that's one of the things that we look at when we talk about that uptick in mood or that sudden elevated mood that we want to try to tease out with folks if we can, especially if we know their baseline is very different.
Mhm.
Just wanted to add that.
Thanks, Dawn. And Sage, you bring up a good point, right? Good saying goodbye can mean a lot of different things, right? It doesn't just have to say, uh, goodbye or thank you so much, right? Just the person saying it or acknowledging the relationship, acknowledging the friendship, can be a form of or a way to say goodbye. Even just like reminiscing sometimes, remember that one time where you really, really helped me. Wow, you're such a great friend. Thank you so much. That can be an acknowledgement of kind of saying goodbye. And Shannon, you said shame plays a role, deeply embarrassed and unable to face the gaze of judging, imagined or actual others, a real scandalous event, embarrassing exposure, or growing unfolding shame of economic impotence, cultural impotence, unable to protect or care for things they love, dishonor wounds, enough dishonor kills. Yeah, I mean, and I think unfortunately, we are continuing to go through some things in the world. And that is something that can really weigh down on folks, especially when we're thinking about the economy and financial aspects, right? I know a lot of people are struggling. A lot of the individuals we're working with are struggling. We're all struggling, right? Patrick, you said, I see them all too often. What does someone do when they have a loved one who is so depressed? Jane, severe PTSD, loves in a constant trigger, has guilt from not being the parent they wanted to be, was a victim of assault, been cheated on, been left by all their friends, who's the only reason they are still here is because of their kids. What as a partner can someone do? Yeah, it's hard. We all have um we can all relate when someone is struggling. And I think that's where, as workers, right, we want to pay attention to these warning signs, but we do want to keep focusing on and strengthening these protective factors, right? And it's not to ignore the challenges and the difficulties that individuals are experiencing, but bringing and kind of shifting and helping to shift their focus to these protective factors. This is something that can be really strong and really helpful for people, right? Especially when we're thinking about helping folks to develop that resiliency, to build their self-efficacy, to build their self-esteem, to strengthen and reinforce those coping skills, right? This is what is going to provide that protection to the folks that we're working with. The other thing I wanted to touch upon before we kind of get into this assessment piece is providing crisis intervention. And crisis intervention, and I think we've talked about crisis intervention before in our Win for Supportive Housing Learning community. But crisis intervention is really focusing on when someone is in a heightened emotional state kind of crisis. But it can often fall into the sort of web of suicide and suicidality, because when someone is in crisis, their thoughts can often go to this place. But sometimes someone is just experiencing a crisis, and we can provide crisis intervention to that person to help mitigate that crisis. So this is the safer model of individual crisis intervention. And there is a link to this handout here, but these are essentially the steps: stabilize, acknowledge, facilitate understanding, encourage coping, restore functioning, and then refer. So when we're stabilizing, we're really looking to support the person to sort of get from a place where maybe they're here to maybe like down here. We just need to get them a little lower. So if they're at like a 10, let's try to get them to a 5. And that can be done in a lot of different ways, right? So sometimes it could be as simple as saying, hey, you seem really distressed. Can I get you a glass of water? Can I get you a snack, right? Do you need to use the restroom, right? Sometimes we need to get some of those just biological needs met. Sometimes it is going to their emotions and really recognizing and validating their emotions. Sometimes it's helping, like, hey, do you need to sit? And just sometimes it's also just kind of hearing and listening and getting that information from the person. And then we want to acknowledge. And when we're acknowledging, we're validating, right? We're really validating the person's experience. We're validating what we're feeling. We're not agreeing. We don't have to agree, right? So and I say that because sometimes we have a consumer who's in a crisis and they start getting frustrated with us maybe, or they're frustrated with the agency or the landlord. And we recognize that maybe the person is not right or not correct, or maybe their perception's a little off. So we don't have to agree, but we can still acknowledge how the person is feeling and what it is they're feeling, right? You're feeling, wow, you sound really frustrated. You sound really upset. I hear what you're saying. It sounds like you're saying X, Y, and Z. Wow, this must be a really frustrating situation for you. You're feeling really angry about this. Acknowledge how they're feeling, and then you want to facilitate understanding. Okay, you want to let the person know you understand what they're saying. So now we're going to get into that reflective responding, right? We're going to get into what I said a couple seconds ago in terms of like, hey, it sounds like you're saying X, Y, and Z. Am I right? It sounds like this, and happened. Am I correct? And then we can encourage coping. So in terms of encouraging coping, we're really focusing on what they can do in the moment, right? What skills can they maybe employ? Like, hey, I see you're really frustrated and upset. I completely understand. But it might be helpful for you if maybe we use some of those coping skills that we talked about a couple of weeks ago to help regulate your emotions and help regulate what you're feeling right now. Then we want to restore functioning. And again, this is just that process of helping that person get down to a place where we can think clear, right? Getting to a place where the person is able to have a clearer sense of the picture and what's going on and what's happening, and then we can make those referrals, right? Then we can refer the person to their electric company, to the landlord. We can make maybe a community referral to a food pantry and things like that. But in order to get to that place of referring, we want to make sure we're doing these other steps. And I highlight that because I know sometimes when a consumer comes to us with a problem, we want to jump right in and start problem solving. But we can't start problem solving until we support the person to regulate their emotions a little bit more, because we want to acknowledge and validate how it is they're feeling. Because if they're angry and they're frustrated but they need to call the electric company, it's the conversation's probably not going to work out that well if they're really heightened emotionally, right? So we want to support the person in getting a little bit more stable in terms of their emotions and their emotional regulation. Uh, does anybody have any, like when you're providing crisis intervention to any of the individuals that you're working with, are you using these steps? Are you using some of these steps? Do you have a different model of crisis intervention that you all are using? Okay, so Cecilia, when you have somebody in crisis, you typically call the crisis response unit. And yes, when somebody is in crisis and they're saying that they want to um, harm themselves or others, you definitely want to call a crisis response 100%. But what about if you're going to meet with somebody and maybe they're not voicing that and they're just, again, like they got bad news from a friend or family member? Or maybe they are got an eviction notice, or they didn't pay their electric bill, and now their electricity is going to be turned off. So Jerry, you said, oh, no problem, Jerry. The slides and recording are going to be sent to you. So Shannon, you said some of these steps, lots of listening. Absolutely, right? You really, really want to turn your listening ears on and really pay attention to what the person is saying. And just, especially when the person is in a situation where they're not feeling heard, we want to show them that we are listening and hearing what they're saying. Um, Bailia, I want to say, and I apologize if I said that wrong. I like to ask my clients when first meeting them, what are some of their coping skills and what are some of their triggers, so I avoid triggering them further along crisis. That's a really, really great question, especially since you know now that, like, hey, remember when we first met and you told me that, you use X, Y, and Z coping skill when you're feeling this way? Do you think it might be a good idea to use that coping skill right now, right? So that having that information and gaining that information is a really good idea. Karina, you said you've previously used the question, persuade, and refer model for intent that's being voiced. Carrie, you said we are trained for doing these types of steps, although I will say that it doesn't always end up so linearly. We also call the crisis unit. Yes, never happens like that, right? And sometimes you can get down to like facilitate understanding, and the person goes all the way back up, and we have to start over and go back to stabilizing, right? Cecilia, we try to stabilize as much as possible and validate their feelings and concerns, contact external providers, support and resources, absolutely. Rosalita, sit with them, meet them where they are as a peer, walk them through resources and options while empowering them and respecting autonomy, absolutely. We always want to respect autonomy. Make it clear that they are not alone, that there are options, and that you are here to help. Yeah, because when someone's in a crisis, when someone has just gotten some bad news and they don't know what to do or they don't know how to handle it, right? That feels scary. It feels terrifying. And that might come off as anger and that might present as agitation. But inside, it probably is fear, right? It's that fear of the unknown. It's very nuanced, right? It's not black and white what the person's feeling. So showing the person that they're not alone, that they have support, that you can help, probably does a more good than you probably even recognize, Rosalita. Awesome. So let's say the person is in crisis and they are now voicing that they have an intent to harm themselves or others. So the first thing you want to do is assess for suicidal ideation. And you want to get an idea about the type of ideation that the person's experiencing. Okay. So when we're thinking about ideation, this is someone who is thinking about or planning suicide. If they're having a passive ideation, that means that they're voicing a desire to die. That is going to sound like, I don't want to be here anymore, or I wish I wasn't going to be here, or I wish something bad would happen to me, or, what if I just didn't wake up tomorrow morning, right? That is more of a passive ideation. Active ideation is that desire to kill oneself. That is that statement of, I am going to do X, Y, and Z in order to die. Okay. Now, ideations can fluctuate between active and passive. It is very, very common when someone has a mood disorder for them to experience passive ideation. Okay. It's very, very, very common, which is why we need to, as practitioners, assess whether or not the person is experiencing passive or active ideation. If they are experiencing active ideation, that's when we want to, well, regardless of the ideation, we want to assess, right? But just acknowledging that passive ideation is something that does happen for a lot of people. It doesn't necessarily mean they're going to go and try to participate in an activity that would lead them to die by suicide, right? But just recognizing that there is a difference there, okay? In terms of assessing, we can very simply think about this. We want to think about this as Shannon. You said facilitate understanding, reflects competency, displays intelligence, and these are stabilizing things. Not giving advice, but seeking knowledge and wanting to understand is a reassuring disposition. Yes. So to the point where in the crisis intervention, right? Helping the person to understand or getting to a point where you're trying to understand and collaborate with the person as opposed to telling the person what to do. We don't want to do that. Thank you, Shannon. That was a good point to add. So in terms of assessment, we want to think about this very simply as identifying, asking, and using. Okay. So we're going to identify the specific ideations that they have. Okay. So is the person having an active ideation? That means the person is saying, I am going to do X, Y, and Z to kill myself. Okay. Then we want to identify, is there a plan? And you want to identify whether there is an intent to carry out the plan and whether the person has the means to carry out the plan. Okay. And we want to identify these things because that is going to help us to gauge the risk the person is facing. Because as Dawn said earlier, there's a very different thing between someone saying, I'm going to jump out of a plane versus I am going to purchase a knife and I'm going to stab myself, right? Jumping out of a plane, probably less likely than the person having the money and the means to go to a store, purchase a weapon, and then use that weapon to harm themselves. Then you want to ask, right? You want to ask about the person's risk factors. What are their risk factors? Are they experiencing a recent loss? Are they experiencing any of those personal risk factors? Are they a man? Are they a man over the age of 75? Are they an adolescent man? Is there any family history? Is there a media influence? And then you want to use a specific assessment tool. And I have a couple of assessment tools I'm going to share with you. So I'm just going to stop sharing my screen because I have another screen that I want to share. Now, these tools are linked in the chat, not in the chat, in the PowerPoint. So you will have them. And the tools are the Columbia Suicide Severity Rating Scale, which is a very common tool used to assess for suicide. It's the Safety Suicide Screening Tool from SAMHSA. Sorry, I'm having some difficulty pulling up my browser, but it's just coming up. And then it is the ASQ Toolkit. And then I also have something called Is Path Warm that I wanted to share. So I'm actually going to share that first because I forget who it was in the chat asked about something called sad persons. And sad persons is a mnemonic that can be used to assess for risk of suicide. But Is Path Warm is actually the updated version of that. So I like Is Path Warm a little bit better than Sad Persons because, like I said, it is a little bit more updated. But nope, we're not looking at the right thing. But I'm going to share with you Is Path Warm. Sorry, guys. I have to use my personal computer because my work computer is on the fritz today. I'm running a little slow. Okay, hopefully you can see this. Okay, so this is, as you can see, this is an older handout because it has the old suicide prevention lifeline information on it. Now we know it's 988. But this is from the U.S. Department of Health and Human Services. And Is Path Warm stands for ideation, threatened or communicated. So has the person threatened to harm themselves? Or maybe they're just, again, saying, I want to harm myself. Substance abuse, right? We know that substance abuse and using substances is a risk factor, right? So has the person's substance use gotten to the point where it's excessive? Has it increased over a period of time? Purposeless. Is the person feeling like, or have they communicated to you that they don't have a reason for living? Are they experiencing any anxiety, any agitation, any insomnia? Are they sleeping well? Are they feeling trapped and expressing thoughts or expressing to you that they're feeling like there's no way out? Are they expressing hopelessness? And then warm, which is withdrawing. Are they withdrawing from friends, family members? Are they having angry outbursts? Are they seeking revenge? Are they participating in risky acts? Or are there any dramatic mood changes? Okay, so again, these are red flags, and this is a good mnemonic that really, I think, encompasses some of the risk factors we went over. So this is just kind of something to keep in mind. Now, in terms of the specific screening tools, we have Safety, which I'm going to pull up here. And this is actually a pocket flyer that you can use. Again, it has steps to 5 steps to evaluate and triage suicide. So again, it goes over the different risk factors. It has populations that are at increased risk for suicide. It talks about the different protective factors. It talks about suicide inquiry. And then it helps you to determine the risk level and intervention. So if the person has high risk and protective factor, moderate risk, low risk, and then how to document. And this is updated because it does have all the correct information for 988, and it has a lot of different really good resources for all of you. There's also the ASQ screening tool, which is a little bit more structured. So it tells you specifically what to do in terms of asking the patient, what different questions to ask. and how to document it and what steps to go over. And then the final tool is the Columbia Suicide is the Columbia Suicide Severity Rating Scale. Okay. So again, this is an older kind of form because it still has, this is from SAMHSA, but this is the actual tool. So again, this is the risk assessment. So you can kind of check off any risk and protective factors that the person might be experiencing. And then it gets to the questions. Okay. So for questions 1 and 2, you want to ask the first 2 questions. If both are negative, you can proceed to the suicidal behavior. If 1 and 2, if either 1 or 2 is yes, then you want to ask questions 3 and 4. But 1 and 2 are the most important questions. Okay. Have you wished you were dead or wished you could go to sleep and not wake up? Have you had actually any thoughts of killing yourself? Okay. If the person says no to these questions, then typically there's no other action to take at that time other than to kind of go through the rest of the form just to kind of document what the person is experiencing. But if the person is asking yes to these questions, you want to complete the rest of the form and then kind of follow whatever your agency's policy and procedure is. And to your question, Nicole, if a person reports to you that they did have an attempt, I would defer you to your agency and what your agency's policy is on that. Some agencies might just leave it at that and increase services, refer to resources, et cetera, et cetera. Some agencies might go right to the crisis unit and call in crisis. It really just depends on your agency. And that's the other thing I want to highlight. I know we're just at the end, but I really do want to highlight that you always want to follow what your agency's policies and procedures are. Dawn and I are here to give you information, and we're happy to provide that information to you. But if there's anything that we said that is not in alignment with what your agency wants you to do as a policy or a procedure, do what your agency says. We are just here to kind of provide this information and give you a good overview of this topic. But ultimately, you want to do what your agency is asking you to do. So if your agency says, even if the person has a passive ideation to call crisis, right? That's what you want to do. Is there anything you wanted to add, Dawn?
No, I don't think so.
Okay. So the last thing I wanted to highlight, and we have a couple of minutes, but I want to highlight some resources here. And I also want to invite you to share in the chat any resources specific to Washington that in terms of like peer lines, warm lines, hotlines, anything that you think might be helpful for all of you that you want to share, put it in the chat box because I did try to look for some Washington state specific resources, but had a lot of difficulty doing so because Washington state is really, really big. You're a lot bigger than New Jersey. So feel free to drop stuff in the chat and I will add it to the last slide of this PowerPoint. But the first thing I wanted to highlight is 988. As everybody should know at this point, the National Suicide Hotline has changed from the 1-800 number it used to be to 988. So all you have to do is dial 988 for somebody in a mental health and substance use crisis. And that number will then direct you to a provider in your state, in your county that can then facilitate assessment for you, okay? Anyone can call, chat, or text. It's free of charge. It's 24 hours a day. You can also go to the website and chat. And on the Lifeline, a trained crisis counselor is going to provide support to the person in crisis, as well as anybody that's with them. Now, to kind of differentiate between 988 and 911. If someone is in immediate danger, if there's a fire, a crime, or if somebody has already hurt themselves, you want to call 911. Okay, immediately call 911. But if someone is having suicidal thoughts or they're experiencing a mental health or substance use crisis, you want to dial 988 and you can get that person some support. So Isabel, you put something good in the chat. You have 988, Washington Warm Line. Good. You guys are giving me some good stuff. The other thing I want to just put in the chat really quickly is our evaluation, and ask you to fill out the evaluation for our webinar today. So this should say Washington resources, not New Jersey resources, so my bad. But basically what I have and what I was able to find was you have a peer warm line, which is 877-500-9276, which Sage you gave me. Thank you very much. And I also have the Washington Recovery Helpline, which is 866-789-1511. So any other resources you put in the chat, I will add to this. I also know that there is a list of the county crisis lines, and I will add that also, just so that everybody kind of has it. But these are the resources I have so far. So any other additional resources you want to send me, I would be happy to add to this PowerPoint. So it goes out when the PowerPoint is sent. So Dawn put, or I put the evaluation in the chat. Make sure to fill out the evaluation. We value your feedback. We love your feedback. Any feedback you can give us is very, very helpful. But with that, I will say thank you. I know we are just about at time, and I do want to respect everybody's time. So thank you so much for your time and attention and your participation and engagement. Today's webinar was hosted by DBHR through the Washington Healthcare Authority. I do just want to remind everybody that the slides and a link of the recording session, as well as other resources, are going to be available in a follow-up email. And don't forget to check out the Foundational Community Supports newsletter for all things FCS and upcoming training events. I'm going to stop the recording. If I can, maybe you can stop the recording, Dawn. Okay, no.